in Sub-Saharan Africa.
Thank you very much, and thanks to the organisers for accepting the late breaker. As you can see, it's done with colleagues also from the London School and Imperial College within part of the framework of the research to help establish some of the basics of the pop art trial. So treatment as prevention, this is in some of the discussions over the last few days, we've had some sort of debates about the evidence versus the feasibility. I think something that we need to acknowledge in those discussions about the difficulties in retaining people through the cascade is that treatment as prevention has fundamentally been a really important tool to focus attention on the need to find ways to enroll people earlier into care earlier. So even if all you care about is treating patients and not necessarily the preventive benefit of ARD, I think treatment as prevention as a concept has been very, very valuable in making people think a lot harder about those issues of enrollment and retention in care. Current testing approaches are definitely failing to identify people enough, even to respond to clinical needs. In some settings, we had this data earlier, less than 20% of HIV positive people know their status, and provider-initiated testing and counselling, the standard way in which many people get tested, is suboptimal, even in high prevalence settings. So this study from Malawi recently showed that less than 10% of people in a clinic setting, in an HIV primary care setting, were being offered testing. So we need better approaches. Home-based testing is a proposed strategy to increase access to testing in Sub-Saharan Africa and elsewhere. And there have been a number of individual studies over the years that have suggested reasonably high uptake. And there are studies that WAFA presented and I also presented that showed that home-based testing is potentially an effective way to catch people earlier in their disease progression. People entering care via home-based testing have a higher CD4 than clinic-based testing. But there's been a lot of debate, and we've heard it over the last few days, about acceptability, effectiveness, and the potential stigma and discrimination and other human rights violations that might accrue through a door-to-door testing strategy. So this systematic review was designed to look at the evidence for home-based testing to date in Sub-Saharan Africa. We used a very, very broad search strategy, but the trade-off for that was we only looked at 3 databases, and we limit terms to any country in Sub-Saharan Africa and did a meta-analysis, meta-regression, and sensitivity analysis to look at potential determinants of uptake and test results. So we screened 1,200 papers and got down to 18 papers that actually presented results from 20 studies, because 2 of the papers presented 2 different studies within the same paper. So we're looking at 20 studies. They were published from 5 countries: Uganda, Malawi, Kenya, South Africa, and Zambia. And over 520,000 people had been approached for home-based testing. So quite a substantial number of people offered home-based testing in the past 10 years in that setting. Sometimes even in this conference, home-based testing is almost being discussed as an experimental strategy. Well, in fact, we've got an enormous amount of experience already on home-based testing. Most studies use lay counsellors to do the testing. They use rapid diagnostic tests. They had protocols for confirmatory testing and tiebreakers in case of discordant results. 3 studies provided incentives for participation, and 7 studies used pre-test community sensitization campaigns. Got 3 sets of results. Of those offered testing, how many accepted? This is the first pooled estimate for that. Some 82% of people on whose doors were knocked accepted to be tested. The second result is of those accepting to test, how many of them received their result? And there the figure was very high. 99% of people accepting got their result. And then this is the overall of anyone whose door was knocked on, how many got a result, and it's 76%. I'll just indicate, not sure how to use this. No, I won't. But I'll say that the second study down has a very low, it's 24%, and that's a study done in the pre-ART era. So it's yet more evidence for this concept that we were all playing with a decade ago, that providing treatment is an incentive to know your status. Well, it just goes to show that in an environment where people were offered a test but nothing else, they were very, very reluctant to actually accept that offer. In meta-regression subgroup analysis, there was no influence in uptake of receipt of results according to HIV prevalence. These were dichotomized meta-regressions that was below or above 10%. Study period, we used a cutoff of 2005 as pre-scale-up of ART and post-scale-up. Provision of incentives and post-test sensitization campaigns. These were surprising results, but we couldn't find any influence in our meta-regression of these kinds of initiatives in the eventual uptake of testing and receipt of results. We did find some influence in the use of where the point-of-care testing was done, so the rapidity in getting the results back to people. And we did see some evidence that in testings with a high proportion of patients had previously received a test, uptake was lower than in those places where there was a low proportion of patients. So that points to the potential problems we might see in environments of repeat test campaigns. But it's a sensitivity analysis, you can only be suggestive. No evidence of harm reported in any of the studies. We specifically looked for that. 3 studies did note that stigma and discrimination could account for non-acceptance in the discussion, but in fact, even those studies reported relatively high rates of acceptance. One of them had a 98% rate of acceptance, but nevertheless still hypothesized that there were concerns. So I'm not sure to what extent we really need to take those concerns into account. Half of the people tested were men. This contrasts with clinic settings where often women are much more frequently tested than men, so it's potentially a way to get more men into care. And as I say, the lowest result was in the pre-ART era. Some of the things we weren't able to capture, unfortunately, CD4 count, that data was not extractable, and linkage to care from receipt of result into ART care, that data was not available either. So strengths and limitations, a large sample size, limited number of databases, and limited geographical scope. And in conclusion, we would say that home-based testing appears to be an effective and acceptable way to increase testing and provision of results. Over three-quarters of people offered a test, accepted and received their result. Future research is obviously needed to look at the point about incentives and sensitization campaigns, because that has a cost attached to the program, and so we really need to know whether it's worth doing those things or not, and the overall cost effectiveness and linkage to care. Thank you very much.